The next session is Special Lecture 3. This session will be chaired by Dr. Satoshi Mochida. Dr. Mochida, please.
Now, we would like to receive special lecture by Professor Jia-Horng Kao. Title of the lecture is Development of ACC in HCV patient. Time is limited, so I will introduce the CV of Professor Kao briefly. Professor Kao was graduated from the College of Medicine, National Taiwan University in 1987 and received his PhD from the Graduate School of the same university in 1994. And now he is a chair professor of the Graduate Institute of the Clinical Medicine, National Taiwan College of Medicine. In 2012, he served as the president of APASL meeting in Taipei. Now, Professor Kao, please start your lecture.
Okay, thank you so much for your kind introductions, Mochida Sensei. And first of all, I would like to thank Professor Ueno and the organizing committee for inviting me to this Apostle Oncology 2023 in the beautiful city of Sendai. And my task today is to present the development of HCC in HBV patients. I'm Dr. Jia-Horng Kao from Taiwan, and these are my disclosures. So in the following 30 minutes, I would touch on the overview of HCC, the HBV-related HCC in untreated and treated HBV patients, and how to implement HCC surveillance in HBV patients, and lastly, how to prevent HBV-related HCC. So as you know, hepatocellular carcinoma is the 7th most common cancer worldwide, with estimated 0.1 to 1 million new patients per year. And it is also the second leading cause of cancer-related mortality, with about 600,000 deaths globally. And the hepatocellular carcinoma has a striking different geographic distributions, with a very high prevalence in Asia-Pacific region and also the sub-Saharan Africa. HCC has a changing incidence, and it is increasing in many countries. So this heat map shows the global mortality of primary liver cancer in 2018. And you can see the HCC-related mortality remains very high in some Asia-Pacific countries, including Mongolia, China, and Southeast Asian countries. In addition, the incidence is changing. It is declining in Africa, East Asia, but it is still increasing in Europe, America, and some Oceania countries. Regarding the etiology of liver cancer, I think cirrhosis is the most strongest risk factor for the development of HCC, followed by the chronic viral hepatitis, HBV, HCV, and the Delta virus infections. The toxin exposure is also important, with some hereditary metabolic liver disease, autoimmune hepatitis, and the clinical significance of non-alcoholic steatohepatitis or MAFOD has been increasingly recognized in recent decades. So this map shows the global incidence of liver cancer in 2018. So you can see the burden of HBV-related HCC is very high in the Asia-Pacific countries. In fact, the HCC accounts for 80 to 90% of the primary liver cancer in our region. And in East Asia, so except in Japan, the chronic hepatitis B is the leading cause of liver cancer. So let's move on to HBV-related HCC in untreated HBV patients. So this figure shows the infants born to HBV carrier mothers have a very high likelihood of becoming chronic infections, although with inapparent liver disease. And unfortunately, 2/3 of them will become inactive carrier by the age of 40 years, and 1 to 2% of these inactive carriers will enjoy the loss of surface antigens, or so-called functional cure. So this is the favorable clinical outcome for them, and antiviral therapy may not be required in these inactive carriers. In contrast, 1/3 of them may experience the chronic hepatitis and progress to liver cirrhosis or even a hepatocellular carcinoma with a variable incidence. So these adverse outcomes, because of this adverse outcome, these patients are in need of antiviral therapy to prevent or delay the disease progression. So in a recent systematic review and meta-analysis, we can see the 5-year cumulative HBV-related SCC risk according to the regions and also the liver disease status. So in the right-hand side, you can see the SCC cumulative risk in Europe. So after 5 years of follow-up, the SCC risk is 0.1%, 0.6%, and up to 10% in inactive carriers, chronic hepatitis patients, and the patient with compensated cirrhosis. In contrast, in East Asia, the SCC risk in inactive carriers, chronic hepatitis, and the compensated cirrhosis is 0.3%, 2.4%, and up to 16%. So it seems the Asian HBV patients have a higher risk of SCC than the European patients, probably due to the duration of infection, HBV genotype, or the genetic background. So this table summarizes the overall annual incidence in untreated chronic HBV patients. So it is 0.3% for asymptomatic carriers, 0.05% in inactive carriers, 0.4% chronic hepatitis, and up to 3% in compensated cirrhosis. And how about the risk factors? It has been demonstrated the OH, male gender, and the genotype C infections compared to genotype B are the strong risk factors for SCC development. So with recent data, so this table summarizes the risk factors associated with SCC in untreated chronic hepatitis B patients. So the viral factors such as E antigen positivity, high viral load, HBV DNA integrations, genotype C, the co-promoter mutation, the high HBs antigen level in a patient with low viral load, or the high HBsAg or hepatitis B core-related antigen level in patients with intermediate viral load. I will highlight these two issues in my later presentations. So the host factors, the male gender, OH, family history, advanced fibrosis, or even cirrhosis. The concomitant of diabetes, a non-alcoholic fatty liver disease, or the anti-CpGG allele. And the external or environmental factors include alcohol, cigarette exposure, aflatoxin, co-infection with other viruses, and air pollution, such as the PM 2.5. So this cartoon shows the life cycle of HBV replication and also with its quantifiable viral markers. So we are quite familiar with these, such as hepatitis B surface antigens, HBV DNA, and recently the HBV RNA and also the HBsAg has been increasingly recognized. So with these biomarkers can help the management of our patients with chronic HBV infections. For chronic hepatitis B, we can have markers for HBV transcriptional activity, such as HBV DNA level, the quantitative HBsAg, HBsAg, and also the HBV RNA. And for patients with liver cirrhosis, we have markers for fibrosis severity and predictor of SCC, such as FIFO index, N2-BPGI, and transient elastography. And for SCC, we have the marker for surveillance, such as alpha-fetoprotein, PIVCA2, AFPL3, and recently the GALA score. So regarding the HBsAg, so I think our previous data, the eradicate B cohort, our data showed that the higher the baseline HBV DNA level, the higher the risk of SCC development over time, which is similar to the review HBV study by Professor C.J. Chen. However, as you can see from this, so the risk of SCC in patients with HBV DNA less than 2,000 or less than 200 are very similar. Therefore, at that time, we introduced the quantitative HBsAg. So if the level is above 1,000 IU per ml, this patient indeed have a fivefold increased SCC risk than those with a low surface antigen level. And another viral markers, that is HBsAg, we found that if it is more than 10 kilonewton per ml, can help stratify the risk of SCC in patients with intermediate viral load, that is from 2 to 20,000 IU per ml with the adjusted Hazard ratio of 7 after 20 years of follow-up. So by using HBV DNA, S antigen, and HBsAg, we proposed an algorithm for the risk stratification of untreated e antigen negative chronic hepatitis B patients. So for this patient with normal ALT, we will check HBV DNA. If level is high, more than 20,000, they belong to the high risk group. And if the HBV DNA is intermediate, we will check the HBsAg. If it is more than 10, so these patients are still in the high risk group. If it is less than 10, so they will categorized as the minimal SCC risk. The annual incidence is only 0.08%. For patients with low viral load, less than 2,000 IU per ml, we will check the HBsAg. If it is more than 1,000, so it is in the intermediate group. Less than 1,000, minimal risk group. However, this algorithm needs to be validated by further prospective studies. There are another fibrosis marker, that is fibrosis 4 index, or FIB4 in short. So it is a surrogate marker for liver fibrosis. It contains 4 parameters: age, AST, ALT, and the platelet counts. So our hypothesis is that a higher FIB4 index is associated with a higher SCC risk after long-term follow-up, and the low FIB4 index complements the current criteria to define the true inactive carriers with the lowest risk of SCC. So our earlier study showed that the FIB4 of 1.29, or you can say 1.3, can stratify the risk of SCC in our eradicated B cohort patients with an adjusted hazard ratio of 2.3 after 20 years of follow-up. Therefore, with these non-viral and fibrosis markers, so there are many SCC risk scores developed for untreated HBV patients. And among these risk factors scores, I think the RICH-B is most popular in our clinical practice. The RICH-B score contains 5 predictors. That is gender, age, ALT, e antigen status, and HBV DNA level, and they have different risk score. For example, if the cumulative risk score is 12, then these patients' SCC risk at 3 years, 5 years, and 10 years are 2.3%, 5%, and 13% respectively. And you can see, so this table shows the risk scores of this SCC development, and we can see their 5-year AU-ROC. Among these SCC risk scores, the RICH-B2 has the highest AU-ROC because it contains more predictors: age, male, e antigen, HBV DNA, S antigen titer, HBV genotype, and the family history of SCC. However, as you can see, most of these SCC risk scores, they are HBV DNA based. So our recent collaborative study with Dr. Hosaka in the Toramon Hospital, we are trying to develop the HBsAg based risk score to predict SCC. And the derivation cohort is from Taiwan. This is the eradicated B, and the validation cohort is from Japan. So these two tables shows the comparison between these two cohorts. And you can see from this AU-ROC curve, so we use the ASLD to define the gray zone patients. And we found that our gray zone SCC risk score RICH-B score and the CAG-ACC risk score, and also the CU-ACC score. We found that to predict the 10-year and the 15 years of ACC. And our gray zone ACC score performed better than other risk scores. And with our gray zone ACC risk score of 8 can stratify the ENG negative gray zone patients to high risk and low risk groups. So as you can see, not only in the Taiwanese cohort, but also validated in the Japanese cohort. If the score is above 8, so the risk is very similar to the immune active chronic hepatitis B. If it's less than 8, the risk is very similar to the inactive carriers. So I think this score can be very easily used in our clinical practice. The paper will be published soon. So how about the HBV-related ACC in treated HBV patients? I think most of the doctors have this treated patient in your hands. So how to define their risk of ACC? We all know that the ideal goals of HBV therapy is to cure both a virus and also the progression of liver fibrosis, as shown in this figure. In our previous study, we can see the reduction in HCC mortality through the National Viral Therapy Program since 2003 in Taiwan. And reduce the rate of HCC mortality, we can see in all age groups by 5 to 8 years after the introduction of the therapy program. And our real-world C-team study also showed that the entecavir-treated cirrhosis patients have a lower risk of ACC compared to the historical control cohort with a hazard ratio of 0.4. So implying a 60% reduction of ACC in entecavir-treated cirrhosis patients. However, our further analysis showed that there is a right shift of the lifetime accumulated incidence of ACC in entecavir-treated patients compared to the historical control, suggesting the ACC may not be prevented but just delayed. Therefore, the ACC surveillance should be continued in elderly patients who receive the NUC treatment. And another nationwide cohort study from Taiwan showing that the patient treated with NUCs after 7 years of follow-up, the cumulative incidence ACC around 7% compared to the untreated controls, that is 22%. And in this analysis, no treatment, old age, male gender, and the cirrhosis are the risk factor for ACC in NUC-treated patients. However, the use of statin or NSAID or aspirin seem to have a protective effect, but however, this need to be validation further. In China, they have a study to show the patients, the cirrhosis patients who receive the NUC therapy, the 5-year cumulative incidence of ACC is around 7.4%. And the alpha-fetoprotein and the gamma-GT at the month 6 of antiviral therapy are associated with the risk of ACC over time. And in Korea, so this is a 2-year landmark analysis by using their historical cohort study, the cumulative incidence of ACC in the entire cohort. They found that the earlier ALT normalization during the NUC therapy is associated with decreasing risk of ACC. And this association is independent of fatty liver at baseline and also the virological response during treatment. Another study from Hong Kong, they demonstrated the viral suppression indeed decreased the incidence of ACC, but the patient who lost surface antigen had the least risk, as shown in this slide. So if the patient has no complete viral suppression, the 8-year ACC risk is still high. So therefore, for this patient, we need to have a profound viral suppression to undetectable level, would be better. And in Japan, Dr. Hosaka reported the impact of HBCIAG at 1 year of antiviral therapy on the risk of ACC, either in both E positive and E negative patients, although with a different cutoff. In Taiwan, we use the M2-BBGI, which the Japanese colleagues are quite familiar with. It is a fibrosis marker, but it may also an inflammatory marker. So the baseline M2-BBGI of 1.7 can predict the risk of ACC in our treated HBV patients after 10 years of follow-up. Our another study with a special focus on cirrhosis HBV patients. And we found that the higher M2-BBGI level, that is greater than 3, at the virological remission can predict the risk of ACC and even mortality in such patients. So with this data, there are also ACC risk scores for treated HBV patients. But however, as you can see from these predictors, many of them are non-modifiable. For example, the age, gender, platelet count, cirrhosis status. So how to implement the ACC surveillance in our HBV patients, either treated or untreated? So these are some international recommendations from the ASLD. So a patient with liver cirrhosis, the surveillance is recommended in a child stage A or B. Individual in child C should only undergo surveillance if they are eligible for liver transplantation. And the ESO guideline, the surveillance is recommended in child Q A and B, so it's very similar to ASLD. In APASO, the surveillance is recommended for individual with cirrhosis, and for patient with chronic hepatitis B without liver cirrhosis, the ASLD suggests the surveillance from endemic countries age about 40 years, and the women with endemic country age about 50 years, and the people from Africa, people with family history of ACC, and the people with a page B score more than 10. And APASO, the surveillance is recommended for Asian male age above 40 years, and Asian women age above 50 years, the Black people age above 20 years, and the people with a family history of liver cancer. So it's very clear. How about in Taiwan? So in Taiwan, we use ultrasound and alpha-fetoprotein for the ACC surveillance, and these are also reimbursed by our national health insurance. And the PIPUCA2 in the guideline is not recommended. However, it is reimbursed if in cirrhosis or ACC patient after curative therapy, so it can be done every 2 times a year. Sorry. And for those with a CT or MRI, so it can be done in the guideline, especially in high risk patients. But sometimes it is not reimbursed by the national health insurance, and this kind of ACC surveillance usually performed every 3 to 12 months. So although we have international guideline for these recommendations, from the real world data, we can see these surveillance are is not very well utilized. For example, for patients with cirrhosis, the utilization is less than 25%, and for chronic hepatitis B patients is around 33%. So why these surveillance are underutilized? Because there are many variable points in our surveillance cascade. So these checkpoints need to be overcome one by one. So because of this, so there is a new concept we so-called the precision ACC screening. So we can screen this patient with chronic liver disease by using some biomarkers to have risk stratifications. So for patients with high ACC risk, they should have, for example, the screening intervention 1, more intensive screening. And for patients with low risk, I think maybe the surveillance is not required for this patient from the budget point of view. So we need some new biomarkers for the risk stratification to perform the precision SCC surveillance. So there are some study showing that, for example, the GALE score, it has been conducted in a phase 3 clinical trial. Now we are in the era of artificial intelligence. So how can we use this AI in our clinical application for hepatology? I think we can use the routine clinical laboratory data, the radiology-based image recognition, radiomics, and some pathology-based image recognitions. Also use the multi-omics, the natural language processing, and the real-time bio-monitoring. So there are some good examples. This is a paper from Korea. They use the AI-driven model for HPV-related HCC screening. So this is a Plan B model. And they use machine learning approaches in entecavir or tenofovir treated patients. So the parameter is quite simple: cirrhosis, age, platelet count, antivirus, sex, ALT, DNA level, albumin, bilirubin, and E antigen status. So they have a derivation cohort and the validation by Korean cohort and also a Caucasian validation cohort. You can see its performance is better than the traditional risk score, as I just mentioned, the PAGE-B score, REACH-B score, or CU SCC score. So in my hospital, my colleague, Dr. Su, also performed a personalized risk scores for HCC using the routine sequential laboratory test and the deep learning. So we call it the STI model. So the results show that this STI model can be used in many etiologies, including HBV, HCV, cirrhosis, or NAFLD. And its performance is also better than the REACH-B, PAGE-B score. But however, this kind of AI-driven score or machine learning need to be validated by further prospective studies. So lastly, how to prevent HPV-related HCC? I think the preventive strategies is very simple. We have a primary prevention to target the total population by using the universal HPV vaccination. And we can use the antiviral prophylaxis for high viremic carrier mothers. And we can also interrupt the horizontal transmission. The secondary prevention is to target the HPV patients without SCC. The antiviral therapy with a monitor on the compliance, efficacy, and the possible drug resistance. And of course, we should continue the SCC surveillance in treated patients. And the tertiary prevention is to target the patient with SCC after curative therapy. We can use the antiviral therapy to improve their liver reserve and reduce the recurrence of SCC after a curative treatment. So with this, I thank you for your attention.
Thank you, Thank you, Professor Kao. Elegant and very expensive lecture. In general, please.
Thank you very much for your beautiful talk, and Enomoto from Osaka City. And in host factors, you mentioned diabetes or obesity is a risk factor of HCC development, but it is also associated with surface antigen loss in some report.
Yes.
Could you explain the discrepancy?
Okay, it's a very important and interesting question. Actually, in our recent paper, we use our integrated medical database. We found that with a patient with steatosis, but without metabolic dysfunctions, these HPV patients have a higher likelihood of HBs antigen loss. But however, if they have a more metabolic dysfunction burden, they have a risk of disease progression and even hepatocellular carcinoma. So I think that depends on whether this patient is a simple steatosis or whether they have more metabolic dysfunctions. This may make the difference. In old days, we usually put them together, or metabolic syndrome, steatosis, fatty liver, diabetes, hyperlipidemia. So if we use this general definition, we may not see the difference. But if we divide them one by one, we can see some factors are helpful, some are bad predictors. Thank you.
Any comment, question, please?
My name is Yoichi Asahime University. So I have one question now. So I agree with the HBS antigen loss is the most important factor for the nucleus analog treatment patients. But how about the decrease of the HBS antigen level? So is it also important for the preventing the risk of the HCC?
Okay, that's another very important issue. So in some new clinical trials, so the primary endpoint, usually the loss of surface antigen, there is a functional cure, but we know it is very difficult to achieve. So in the definition of HBV cure, there is a partial HBV cure. It means the hepatitis B surface antigen less than 100 IU per ml. In fact, our previous long-term studies also show that if the patient have S antigen less than 100, they usually do not have the high relapse rate after stopping the nukes. We published a paper in HAG, maybe 2016. If the S antigen at the end of therapy is less than 100, the risk of relapse is only 9%. But however, if it is above 100, the risk may be up to 50 or 60%. So in the future clinical trial, I think there are some endpoint we may set the partial functional cure, that is HBsAg less than 100. So we can try this. And I know that maybe in the JSH, you also have a stopping rule, it's optional. S antigen less than 80, and the plus the HBsIg inactivity can also consider to stop the new therapy. So this may be also our alternative endpoint for our HBV patients. Thank you.
And now time is over. I have to close this session. Finally, please give Professor Kao a big round of applause again.
Thank you so much. Arigatou gozaimasu.
Thank you very much, Dr. Kao and Dr. Mochida.